Welcome back to The Explainer. We're going straight into the trenches today to crack the code of those dramatic, squiggly lines on an ECG. Our main focus, we are zeroing in intensely on the real science and those very specific electrical patterns hidden right behind myocardial infarctions.
Okay, let's dive into this exact phrase from our source material, currents of injury. I love this description because an ECG, it's definitely not just a static graph on a piece of paper. It's a real-time, living electrical map. And when a heart attack strikes, this map captures the deadly, shifting electrical currents of injured and dying tissue exactly as they happen.
So here's our game plan for today. We're going to hit tracing and infarction, structural overload, conduction blocks, metabolic shifts and toxins, and finally, other critical clues. Let's get right into Section 1, tracing and infarction, or the timeline of a heart attack.
Look at how perfectly this tracks the actual timeline of a heart attack. It moves from early ischemia, which you'll see marked by T-wave inversions or those really tall hyperacute T-waves, right into acute transmural injury, where the ST segment physically elevates on the tracing. And finally, if it goes unchecked, it results in necrosis, leaving behind those deep pathologic Q waves.
You've got to see the stark difference here, and it's all based on the depth of the damage. Subendocardial ischemia, which is partial thickness damage, physically pushes the ST segment down. But acute transmural injury, that critical full thickness damage, literally pulls the ST segment up. And boom, that is your classic STEMI. It's a massive medical emergency.
Now, spotting these ST changes, it's definitely not just trivia. Looking at specific leads is honestly just like changing camera angles on a security feed so you can localize exactly which wall of the patient's heart is dying. Leads I, II, and AVF act like a camera looking straight at the inferior wall, while leads V1 through V6 point directly at the anterior wall. You are literally pinpointing the exact location of the infarction.
But what if we're too late? If we don't intervene in time, the ECG leaves us with these permanent scars, pathologic Q waves, and a massive loss of R wave amplitude. This definitively signals that the muscle tissue has necrosed. It's dead, and it's permanently lost its electrical charge. The detective's trail has basically gone cold.
Moving right along to Section 2, structural overload and the architecture of the heart. Let's shift our focus up to the atria for a second. Depending on which upper chamber is struggling, the P wave completely changes its shape. If the right atrium is overloaded, that P wave spikes sharply upward into a peak, usually at least 2.5 millimeters high. We call this P pulmonale. But if the left atrium is the one struggling, it stretches out into this broad, double-humped notch known as P mitrale.
Now, when the lower ventricles massively thicken, they generate some seriously huge voltages on the ECG. Right ventricular hypertrophy gives you a very tall R wave in V1. But left ventricular hypertrophy creates these massive R waves on the left side and incredibly deep S waves on the right. More importantly for us, LVH often shows an ST strain pattern with ST depression and T-wave inversion. As detectives hunting for infarctions, we've got to be super careful to distinguish this structural strain from actual ischemia. It's a notorious mimic.
Okay, Section 3, conduction blocks, or what happens when we're essentially cutting the wires.
120 milliseconds. I need you to lock that number in your brain right now. If the QRS complex, the main spike of the heartbeat, is 120 milliseconds wide or wider, the heart's normal fast-track wiring is broken. You are officially looking at a complete bundle branch block.
Notice how a right bundle branch block gives us that distinct extra upward spike in lead V1, known as the RSR pattern. But a left bundle branch block creates a deep negative canyon in V1 and a broad positive wave in V6, completely disrupting the normal septal depolarization sequence. And here's exactly why this matters for our infarction investigation. An LBBB wildly distorts the ST segments. It makes it notoriously difficult to spot an active, ongoing heart attack hidden right underneath it.
Now, what if only a smaller branch is blocked? Say, the left anterior fascicle. Well, it actually won't widen the whole complex all the way to that 120 millisecond mark. Instead, these hemiblocks wildly shift the electrical axis of the heart, usually throwing it far to the left.
That brings us to Section 4, metabolic shifts and toxins, our chemical suspects.
Potassium is an absolute heavyweight here. High potassium, or hyperkalemia, is a massive, urgent threat. It literally morphs the ECG. It starts with tall, tented T waves, then it widens the QRS, and ultimately deteriorates into this terrifying sine wave pattern right before cardiac arrest. On the flip side, low potassium leaves behind mysterious U waves and ST segment depression, and yep, that's yet another pattern we absolutely must differentiate from the ischemia of a heart attack.
Calcium, on the other hand, operates on a totally different timeline. It heavily affects the QT interval. Too little calcium stretches the QT interval out by prolonging the ST portion, but too much calcium, it squeezes it tightly together.
And trust me, a stretched QT interval is literally a ticking time bomb. We must always be on the lookout for drugs, like the antiarrhythmic amiodarone, that stretch that QT interval. Why? Because it opens the back door for a lethal condition called torsades de pointe. It's an incredibly dangerous, twisting ventricular rhythm that can easily be fatal in minutes.
Speaking of drugs, let's talk about digitalis. This toxicity leaves its own unique, undeniable fingerprint on our electrical crime scene. It famously causes the ST wave to look scooped out. Honestly, it looks almost like a ladle just took a chunk right out of the baseline. Once again, noticing the specific shape of this ST depression is exactly how a good detective knows it's the drug talking and not a blocked artery.
Finally, let's hit Section 5, Other Critical Clues, the final pieces of our puzzle. If you're ever looking at a tracing and see the QRS amplitude just bouncing up and down, beat to beat, tall, short, we call this electrical alternance. It is a massive red flag. It's telling you the heart is literally swinging back and forth like a pendulum inside a sac filled with fluid, which is a critical emergency called cardiac tamponade.
Plus, if you're seeing generally muffled, globally low voltages everywhere, it's a huge hint that something physical is dampening the signal between the heart and the skin. We're talking fluid, the hyperinflated lungs of emphysema, or even severe obesity. And what about the environment? Freezing temperatures from hypothermia cause a really slow heart rate and produce these very distinctive tiny little notches at the end of the QRS complex. We call those Osborne waves. We have decoded so much today, from those strict 120 millisecond bundle branch blocks to the crazy chemical mimics, all while keeping our main focus locked onto that fatal step-by-step progression of a myocardial infarction. It really leaves us with one final thought to reflect on regarding the sheer power of this tool. If an ECG is all just a collection of peaks and valleys on a grid, how many more lives could we save if we all learned to trace these currents of injury, reading the exact dying wall of a human heart, hidden right there within the lines? Thanks so much for exploring this amazing clinical map with me. Keep learning, keep questioning, and I'll see you on the next explainer.